particularly delicate the phase of information. About the food, of course, critical ischemia, you can see here root 4, 5, and 6, Wi-Fi 1, 2, 3, gangrene extended, so huge and huge wounds are excluded, of course, infection are excluded, and of course, no other option. Anatomically, this is the original scheme of the four-foot system, four-vein foot system from Legua, who was a Peruvian vascular surgeon who first had the idea to check the venous system. You can see here, anatomically, what Mariano is doing is trying to give to this food an inflow and an outflow. You can see here the deep dorsal system with the anterior tibial veins. You can see here the posterior and the plantar system with the posterior tibial veins and the medial plantar veins and the lateral plantar veins with the deep plantar arch veins. This is the forefoot cross, so the perforate in the forefoot vein, in the forefoot of the foot is, of course, in the forefoot. And the system, the particular system called the Lechar's sole, the veins appearing in the plantar side of the foot. And this is the foot. This is what we are looking for. This is the superficial dorsal system, the great saphenous vein with the medial marginal vein, with the communication in the forefoot. So we could see the first step, surgical, the second step, endovascular, and the purpose is to cross all the valves, trying to achieve a rupture of the valves, arriving to have an outflow in the first vein and the arch. And we can discuss about the embolization of the early collateral branches stealing the flow from the foot. The third step is very important, the follow-up. We have to stay aggressively with the patient. Follow-up is really, really important. Clinical follow-up for the aspect of the foot and ultrasound Doppler follow-up of the vein in order to realize the early problems of recoiling or restenosis of the valve in the vein. So very often we need a second endovascular step with checking of the separation, reopening eventually the bypass or the vein, and to redirect the flow towards the forefoot, of course, and at the end, the foot surgery step. So when everything is stabilized, we could proceed to, for example, to a transmetatarsal amputation. This is the moral access technique by Andrea. You could see the isolation of the sapina. This is the mechanical thrombectomy in the proximal part of the vein before doing the proximal anastomosis. And you can see here the aspect of the anastomosis with the vein inflated by the arterial flow, and the aspect of the access in the popliteal area. I can jump the description. This one. Come on. Okay. You could see in the real time during the life all the procedure. What I would like to underline is, of course, sometimes could be difficult to advance our catheter and our wire through the valves because of the sometimes we may have spasm of the vein, so it's difficult to enter the valvular lanes. You can see it's easy to go in collateral. We may spend a lot of times. In this case, Mariano decided to directly embolize. You can see here the catheter, for French catheter, directly embolize the first collateral, proximal collateral, very, very close to the proximal part of the bypass, in order to redirect the flow down to the ankle. So we need, of course, a system, a coiling system. We use the Harry or the Tornado, Vortex, any kind of coil is able to close our branches in order to let the flow arrive in the distality. Another aspect is next, how to destroy the valve. We can use balloon. You can see here, this is a Dorado balloon, so from BD is a high pressure, non-compliant balloon. You can see that valve, how resistant it is. That valve in the malleolar area of the posterior tibial artery, posterior tibial vein, in this case, is really resistant. We may find really a resistant valve. If I remember well, with Bruno, we could open that valve with a 6 or 7 millimeter balloon inflated at 30 atmospheres for 2 minutes. You can see how difficult it is. Then we could use, when available, of course, a reverse valvulotomy. You can see here the advancement of the device. Of course, the idea is the antegrade progression of the valve tone. So we can see the valve and push our device in order to cut the valve. But there are actually no antegrade valvulotomy in the market. We only have retrograde valvulotomy. So we have to push the device into the arch and then pull back completely. And this could be a risk because we cannot see what we are doing, of course. And the last option we have is to use what we call the double wire technique. So one wire is crossing over the valve, and a second wire, the 1-4 wire like command ES wire, for example, has been looped, and we push and pull in order to capture the cuspid of the valve and cut or break or damage that part of the valve in order to achieve the incompetency of the valve. Another important aspect is the day after the procedure, when everything is working and the flow and the perfusion and the amount of perfusion in the foot is huge, is to ask the patient to walk, stand and walk, just this is really important to avoid the swelling, to avoid the pain, to avoid the complication included in the food store syndrome after the arterialization. And then it's really important to check clinically the patient, ask about pain, and check with ultrasound the situation. It's important, let me, sorry if I jump up and down, but I would like to show you the final aspect of this food after the first arterialization. You can see here the inflow. We have to wait a little bit, okay? After the final inflation of the balloon, in order to destroy the last pulse, this is the aspect, the acute aspect of this food after this arterialization. Let me show you what's happened 4-6 weeks later. So at the ultrasound Doppler. So again, we check the patient and we realize that, look here, there is a reocclusion. If you remember the coils in the branches, Mariano deployed in the first procedure, we cannot see the inflow and we cannot see the outflow. So it's important to realize that circulation and reopen everything. So Mariano did again the procedure, but what I want to show you is the aspect of the forefoot. Look how different is the aspect of the forefoot after 1 month. Do you remember the first imaging? There were no veins in the forefoot, no distribution, no outflow. Now, despite the occlusion, we have new vessels. That's the unbelievable message of this procedure. Bruno showed us some hypotheses, some physiopathological hypotheses about this phenomenon. We still have to learn a lot about because we cannot understand. But it's unbelievable how we can improve the, in some patients, in many patients, fortunately, the situation in the food. And of course, after 3 months, it was possible to heal the transverse amputation in this patient. About the results of the hybrid procedure, you could see here the sum of positive outcome in 66% of patients was possible to save the capability of walking and the limb saved. Of course, we still have a high percentage, 30%, more than 30% of major amputation, but I remember you that this population is already the worst population with only amputation in its destiny. So we could save in that population 60% of patients. It's not a stupid result. It's a huge result. It's very promising if we could understand why in some patients it's working and why in some patients it's not working. What about towards
we have to speak, of course, honestly, what can happen. You can see here, this is